Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. Today, we're exploring how a groundbreaking class of medications, the GLP-1 agonists, might reshape the way that we manage medications, inflammation, weight, and disease activity in rheumatology. Originally designed for diabetes and obesity, these medications are now capturing the attention of rheumatologists for their potential to benefit disease activity in conditions like psoriatic and rheumatoid arthritis. We'll explore how adipose tissue acts as an inflammatory organ, why weight management matters in rheumatic disease, and how GLP-1 agonists might not just change waistlines, but DAS28s as well. Joining us to discuss these topics is Dr. Catherine Bakewell. She will guide us through the science, the clinical realities, and the promising future of integrating GLP-1 therapies into rheumatologic care. Dr. Bakewell trained at the University of Washington in Seattle, where she attended medical school, residency, and did her rheumatology fellowship. She currently practices rheumatology at Intermountain Healthcare in Salt Lake City, Utah. She's on the board of directors for the Association of Women in Rheumatology and US SONAR, and has been prescribing GLP-1 agonists for her patients with rheumatic disease. Enjoy. Catherine, welcome to the show.
Thank you for having me.
So let's start with the basics. These medications, the GLP-1 agonists, have really become famous. Everybody's talking about them. Can you walk us through a little bit about what they are and what's made them so popular these days?
Absolutely. So, yeah, echo that sentiment. It has really shown up in a major way over the last 1 to 2 years in my practice, to where before I even started looking into them, patients were asking me about them and kind of, if you will, forced my hand into really taking a deeper dive into this. And since reading and learning more about it, was asked to give a couple presentations. And so now I really have taken a keen interest in this and see it as potentially an important part of my practice. So GLP-1 stands for glucagon-like peptide 1, and it is part of a family of hormones called incretins, which are released after someone has eaten. GLP-1 specifically stimulates the pancreas to release insulin, inhibits glucagon secretion, which in turn lowers blood sugar and reduces appetite. And that's what mostly patients notice, is they just don't feel hungry. Some people say, I feel hungry at the right time after I've just eaten a little. And depending upon the patient, some people say, gosh, I just never feel hungry and I have to remind myself to eat, which is in of itself something that I need to talk them through. But I think they are so popular not only because they work and are effective, but because they have a fairly favorable side effect profile. And so we can certainly talk through that. But a lot of folks will have a little bit of GI distress maybe as they start them. But overall, they appear to be very well tolerated and safe. And so I think that combination of efficacy and safety is part of what has made them so popular, because it's not like weight loss medications are new. We've had them for decades, but I think the benefit risk profile is different from a lot of the older agents that we've seen.
Yeah, I think for the first time, my patients come in losing 10, 20, 50, 80 pounds, which was previously totally unheard of unless they had surgery, like bariatric surgery. The success that some of my patients have had with these drugs is really incredible. And as you mentioned, they seem to be pretty safe. Most of them are tolerating it pretty well, and they feel great afterwards. A lot of patients tell me that, this voice that they had in their head that would just prompt them to eat all the time just snapped off and like turned off and is no longer there. And they said, they got their life back because instead of constantly thinking about food, they were able to think about work or their families or, hiking or, any other thing, which is It's great to hear.
Exactly. And anything else they wanted to do, to the point that I have to encourage people again, yeah, remember to eat, remember to get your nutrition and stay hydrated, right? So it's like don't forget that, set an alarm or something.
So, I think these medications were developed for patients with diabetes, right? And then they started been noticing that patients with diabetes lose weight. And, then I think they got indications for obesity. But we're rheumatologists. So why are these medications also interesting for our fields?
Right. And so there are a couple different reasons. First off, obesity is prevalent among our patients. So it's particularly in the field of psoriatic arthritis where I have done the most research and kind of the deepest dive into the effect of obesity on this disease, but it is so prevalent. So particularly for PSA, it's almost half, about 48% of patients with psoriatic arthritis, at least in several cohorts, have had a BMI over 30. And so it affects a significant number of them. And so for this reason, it's so important to address this, not only for the comorbidities, but for the potential impact on disease activity. But even stepping back from psoriatic arthritis in general, you could say, okay, A, heavier weight, increased pressure on lower extremity joints. So patients with osteoarthritis are involved here. And B, adipose tissue itself turns out to be inflammatory. And so, through that mechanism, may be driving both a risk factor for these diseases themselves and then a poorer response to therapy once administered. And so, when you think of this as kind of part of that inflammatory milieu, you begin to think of it differently as a rheumatologist.
Wow, that is super fascinating. So it's not this sort of metabolically inactive tissue, but it may be contributing to inflammation, and whether that's increasing the risk of developing PSA, or if they have PSA already, making it worse, that certainly could be a concern for us rheumatologists. Are there different types of fat, and how do they differ metabolically?
So, yes, no, great question. And this was something that I truly found fascinating. So, I, again, a couple years ago, really only thought of one particular kind of fat, and that's what we think of as the white adipocytes. And you think of it, so there's white, beige, and brown. And the white adipocytes are the ones that are inflammatory for the body. And the idea is all mammals have these three different colors or types of adipose tissue, depending upon both the lineage of pre adipocytes, right? So, kind of what you're born with and genetics, but then also we can alter them with different physiologic stimuli. So a white adipocyte will become inflamed with a high fat diet. So if you think about all the classic offenders from fries and chips and burgers and right, so kind of anything that's high fat content, these cells can become engorged and actually rupture. And that releases free fatty acids into the bloodstream, which is in turn inflammatory. You get this influx of CD8 T cells, which recruit M1 macrophages, which are the angry macrophages. And this ultimately alters the immune system function where we're releasing increased levels of adipokines, which is also kind of a fun word, right? So like a cytokine for adipocytes, you get leptin, resistin, visfatin, adipsin, and these in turn then wind up with higher levels of interferon, or I should say IL-1 beta, TNF alpha, interleukin 6. These are players that we know, right? So we're inhibiting in our clinic IL-6 and TNF. And if you actually think about these adipocytes increasing levels of these cytokines in the blood, then that link becomes very clear. Those are the bad players, right? But through, if you will, transdifferentiation, we can turn our white adipocytes into beige adipocytes. They have higher levels of mitochondria. These are actually metabolically active and can help us burn fat, same as the brown adipocytes, which are a different pre adipocyte lineage. So we can increase our levels of brown, but we can't turn white into brown. We can turn white into beige. But these differences, the idea is, so how do we get more of these metabolically active fatty cells? So it turns out exercise can increase both brown adipocyte content, but then also the transdifferentiation of white into beige. And same too with cold temperatures. And that's a fascinating topic in and of itself. So you've probably heard of the craze around cold plunging and cryotherapy, and increasing brown fat or this transdifferentiation is part of the goal of the cold therapy.
Amazing. And the purpose of the brown fat is like to help with shivering. Is that
Yes,
right?
no, exactly. So when you shiver, it's a stimulus for your body to produce more brown fat. So the people who are, again, kind of fanatics in this, and that's a whole. So people who are resistance training athletes will say, okay, well, right after you lift weights, you shouldn't go get in a cold plunge because you are decreasing microvascular blood flow and decreasing potentially essential amino acid to the skeletal tissue, which may slightly reduce skeletal muscle hypertrophy.
Yeah, I heard about that. Yep.
So right, so that's the downside, but if ideally, if you can cold plunge before, there may be some hormonal effects, a slight increase, for example, in testosterone, which actually promotes then a more efficacious exercise afterwards, right? So the order is important. If you're gonna cold plunge, you wanna do it before you work out rather than after, which see, unless you are an endurance athlete or you're actually trying to reduce inflammation, which the cold plunge can do. So if you've just run a marathon, absolutely cold plunge, or if you're doing the Tour de France, absolutely cold plunge every day after you work out because you're trying to reduce the soreness and inflammation. But if your goal is, to quote, get the gains, then doing so beforehand is better.
Fascinating. Yeah, I also heard about, yeah, just like training in cold temperatures.
Yes.
Out here in Boston, going for a run in the cold can be like very beneficial for the body.
Absolutely. And this is so I was talking with a metabolic endocrinologist, and she says, you realize if you look at the average BMI of a Bostonian versus someone in Texas, it's much lower. And her hypothesis was it's not the Southern fried food, which that's a whole other topic in and of itself. She says that she really believes it's the temperature difference, that because it's colder in Boston, people on average have a lower BMI, which is interesting.
Super interesting. Interesting. Okay, so it sounds like different types of fat, and some of these, especially the white fat, is pro-inflammatory and leads to secretion of all of these pro-inflammatory cytokines that we know and love. So let's dive in a little bit more into PSA. Talk a little bit more about the relationship between obesity and PSA, which you say it's very common, and how that may affect disease activity.
Absolutely. So, several things there. First off, patients with psoriasis who have concomitant obesity are more likely to develop psoriatic arthritis. So, it is a risk factor for psoriatic arthritis development in and of itself. And then if you look at patients with established PSA, they have higher levels of disease activity. And I'll cite just a couple different studies. There's a cross-sectional study by Galarza Delgado et al. This was a 2024 paper that looked specifically at DAPSA scores. So this is disease activity in psoriatic arthritis, and found that patients with obesity had more than double the DAPSA scores of patients without. So obviously a highly statistically significant difference there. Also had nearly double the percentage or incidence of dyslipidemia, hypertension, other comorbidities that we know are associated with obesity. But if you sort of think about your patient as a whole, which of course we should and do, these are important things to address. Another multi-center cohort study, this is one from Liang et al. 2023, exact same findings, significantly higher DAPSA scores in this multi-center cohort in patients with obesity and psoriatic arthritis than those without. And that rang true across a number of different disease activity metrics, things from patient global, CRP levels, overall pain levels, HAQ-DI, so that's that health assessment questionnaire disability index. So all of these statistically higher in PSA patients with obesity relative to those without.
So, are they also harder to treat and harder to get into remission, patients with PSA and obesity?
Unfortunately, right? You're like, you lose and then you lose, right? And so it's all the more important for us to address this. That's absolutely correct, John. So if you take a patient with psoriatic arthritis with obesity, not only do they have higher baseline levels of disease activity, they are much less likely to get into remission with treatment. And I love to cite a study from my colleague, Dr. Jessica Walsh at the University of Utah. So she has the Psoriatic Arthritis Research Consortium. She's got a group that she works with and a large registry of patients with psoriasis and psoriatic arthritis. And unfortunately, across the board, patients with obesity less likely to come into remission. And this is not just psoriatic arthritis. There's actually a study looking specifically at rheumatoid arthritis and patients who are treated. So there was an odds ratio of 0.57 for patients with rheumatoid arthritis who were initiated on either conventional or biologic DMARD therapy. If you looked at sustained remission, it was even lower. So they had a pooled odds ratio of 0.49. So less than half of their non-obese colleagues with rheumatoid arthritis. So this is a bad actor, and this can significantly impact our outcomes for patients.
Yeah, I wonder, like, we typically don't think about their obesity as, our problem. I wonder.
We're busy enough. We try not to take on everything, right?
Right,
Yeah.
right. So we just throw them medications. I wonder, I'm sure we're going to address sort of the role of these GLP-1 agonists and how this may help. But until now, like, is this something that is being addressed in other ways about helping people to lose weight? Is there any data about diet or other interventions that we can help with that may, not only help them with lose weight, but also help with their PSA or rheumatoid arthritis management?
Absolutely. I'd like to think that even, before 2 years ago, when I was aware on a more conscious level of the impact of obesity on inflammation levels, that I was an advocate overall for healthy living, diet and exercise. And that being said, there is a good amount of data that, so as far back as 2018, EULAR made as part of their recommendations for patients with rheumatoid arthritis, spondyloarthritis, and even hip and knee osteoarthritis, that their providers should be talking to them about exercise specifically. So we need to kind of remember that our advocating for this for our patients actually can make a difference in their behavior. And for those who like to delve into specific recommendations, so the American College of Sports Medicine, the American Heart Association, so they're saying, hey, let's get some moderate intensity physical activity for at least 30 minutes, 5 days a week. And then you've probably heard about the HIIT, the high intensity interval training. So vigorous aerobic activity you can actually do for less time if you want more bang for your buck, right? So they're saying if you can do that for 20 minutes, just 3 days a week, that is sufficient as a kind of a bare minimum threshold. And then they say, hey, look, you can break it up. You can do this in like 10-minute intervals. So say you just have 10 minutes before work, 10 minutes during lunch, 10 minutes after work. If you just walk downstairs, you're actually meeting the recommendations for exercise. So that's one thing that I do like to talk with my patients about. But diet is a big topic. And I know that was your original question. I get so many questions about, what about the anti-arthritis diet? Should I be gluten-free? Should I be lactose-free, caffeine-free? Should I be, kind of what should I be doing? And what I can tell people as far as the data are concerned is that most diets out there have benefit on arthritis activity only insofar as it's associated with weight loss, right? So that's kind of where you see the benefit. There's one diet out there that appears to reduce disease activity scores in addition, kind of in an additive way with weight loss, and that is the Mediterranean diet. So you're familiar with that. It's very plant-based, fruits, vegetables, whole grains, a lot of fish, but very little red meat. So you want those omega-3s. You don't want the omega-6s as much. And so that's what I tell people. I think the other diets are hitting on things that certain people are intolerant to. So your patient who is gluten intolerant will absolutely feel better on that arthritis diet that is gluten-free. Or your patient who is lactose intolerant will absolutely feel better on that, right? And so I say you could try an elimination diet. You can talk with your allergist if you're really concerned about other triggers. But if I'm going to recommend a diet to all comers, it will be that Mediterranean diet.
Yeah, I think it's great. I think it's easy for us to say, well, you should get more exercise and you should eat better. It's so hard for people to change their habits. Even for me I like exercising, but to get in a routine to do it, it's really, really hard when you have all these other things that you're juggling around kids and work and sleep. I like your idea of, breaking it into chunks so that, even, 10 minutes, walking to the bus or whatever may help get those 30 minutes of moderate disease activity 5 days a week. And then, maybe sprinkle in some of those high intensity and get it over with in 10 minutes, right?
Right, right. Get it done. And no, and actually, John, you touch on something that I want to speak to as well, which is you mentioned kind of the busyness of life and lack of sleep. And that's something that if you're truly kind of diving deep into weight management, you can think about things like whether it's cognitive behavioral therapy, but just looking at your life and how much stress are you under and how much sleep are you getting? Because, and you probably remember this from residency, right? It's 4 a.m. and you will eat whatever stale donut is out on the wards because your cortisol levels are up. I mean, it's sleep deprivation is a form of stress, and that actually promotes hunger and weight gain. And so making sure that keep stress levels low and get enough sleep. Absolutely. That's kind of it's all part of the package deal. But I do want people to be kind to themselves because you're absolutely right. It's very hard to change habits. What do they say? The average, you have to try 8 times on average to be able to successfully quit smoking. I think that's just changing any habit, right? It's hard to do. And if you have inflammatory arthritis on top of it and you're tired from your disease, maybe your medications have fatigue as a side effect and you've got joint pain that you're dealing with. I mean, it's the cards could be really stacked against you. And so that's where I feel so strongly about offering people additional pharmacologic aid if they need it and they qualify or meet criteria. I think it's sometimes nice to get that jump start.
Yep. Yeah. And in terms of diet, I think you're right. The Mediterranean diet has been, found to be helpful in RA and other diseases and gout. And, interestingly, one of our first episodes here at ACR on Air was on this, what's called the itis diet, ITIS. So like, sort of an anti-inflammatory diet. And we had one of the researchers that has done a lot of work in this. And yeah, it's basically a Mediterranean style diet with some adjustments. And I remember they add in like green tea, which has supposedly some antioxidant properties. But it's great. So Mediterranean diet, so when people ask about diet, recommending 30 minutes of moderate exercise 5 days a week. Anything else? You mentioned the importance of sleep. Do you have any recommendations on stress management?
I joke with my patients, if I could write them a prescription for less stress, I would do it. But no, I would be the most popular doctor in the world, right? In all sincerity, though, I think the main message that I try to give to my patients is to remember that because people, and especially my lady patients, but truly both genders, sometimes we get so busy trying to take care of what we're supposed to do and take care of other people that we barely make time to take care of ourselves. And to just remind folks that when you slow down and you make time for yourself, for self-care, be it mindfulness, be it healthy eating, be it exercise, that you will be able to give back to those around you in spades. This is time that is well spent, and it will allow you to be a more effective, efficient caregiver to those in your life. And it's just so well worth it. So I just try to encourage them that it's not selfish, right? This is for you. This is for everybody around you. This is worth doing.
Yeah. Yeah. I think that's great advice, for us as well.
Right, right, exactly.
Right. Because, work can sometimes be stressful. So, I guess up to now, we've been thinking about, get some improved diet, exercise, improved sleep. Now, talk about a little bit, where do the GLP-1 agonists come into play? You mentioned that, you want to help your patients with sort of pharmacotherapy in the weight loss space. When should we start thinking about these drugs?
Yes. So fortunately, we have pretty concrete guidance from the American College of Cardiology, the American Heart Association, and they are recommending to us that, so for anybody who is overweight, so that's going to be a BMI over 25, then we should start talking about diet and physical activity, behavioral therapy, all the things that we just talked about. But once we get up to a BMI of 27, if they have comorbidities. And so that can be anything from cerebrovascular disease, history of cardiovascular disease, hyperlipidemia, diabetes mellitus type 2, obstructive sleep apnea, right? Sort of all of the obesity associated comorbidities that one might think of. In the presence of a comorbidity, then you have an indication to start anti-obesity pharmacotherapy. So, and that's actually a
It's a lot
fairly
of people.
it's a lot of people, and I think that's a broader recommendation than I think we realize. Like, again, this wasn't forefront on my mind a couple of years ago, and probably because we had some options, but they all come with issues, and so it just wasn't part of our practice. So that being said, now 27 plus comorbidities, and then 30, a BMI of 30 or higher, even without a specific comorbidity that you can name, they are a candidate technically for anti-obesity pharmacotherapy. And I like to make sure that the patient has, tried and addressed diet and exercise. Obviously, you don't want to just do this in isolation, right? And not recommend or encourage lifestyle changes. It's kind of a package deal, and that's really how it works best.
So would you consider PSA or rheumatoid arthritis a comorbidity if somebody has a BMI of 28?
Oh, I love that. So technically, no, but like, could I be encouraged? I think the patient who has, according to our recommendations, that's not a formal, maybe it should be, right? But it's not a formal obesity associated comorbidity. But the reality is that obesity is driving some of the inflammation and disease. And so I think for the patient who, and this is again, just me personally, not guidance adhering, but the patient who has PSA, who has genuinely tried diet and exercise and is so frustrated at their inability to lose those few pounds, and or I am struggling to get their disease activity under control despite going through multiple different mechanisms of action. So the patient who with kind of by definition is difficult to treat, right? That is a patient where they may actually benefit from weight management as part of their disease control. It's possible that, everybody who meets criteria could be in that category, but I definitely have had a few patients where I'm like, I feel like we've tried everything else. What if this is the missing link? What if actually getting you on a GLP-1 agonist or something similar is what's actually going to help your disease come under better control? So I have had that conversation for sure.
So what's the evidence that, it's probably going to, these GLP-1 agonists is probably going to help them lose weight. Does it actually help improve disease control? Is there any data that shows that that's the case?
Yes, great question. So I believe this is an area that we're going to see so much more coming out in the next several years. But what we know so far is that patients who either lose weight from a very low calorie diet, so through caloric restriction. There is a fabulous paper from 2019 that followed patients with psoriatic arthritis on a low calorie diet and looked at many different metrics of disease activity, from the body surface area involved with psoriasis, that DAPSA disease activity and psoriatic arthritis score, the DAS28 CRP. Of course, we see that as a remission metric across PSA, RA, and then that health assessment questionnaire looking at patient function. Absolutely. Across each one of these metrics, it's like a, linear dose response curve with weight loss that they all improve. There we have some proof of concept that, weight loss through caloric restriction improves disease activity. We've seen similar responses to weight loss through bariatric surgery. And it's just, I think, because of a newer interest in pharmacologic assisted weight loss in patients with inflammatory arthritis. We don't have specific results on disease activity metrics yet. Those studies are actually currently enrolling. And so I think in the next couple of years, we're going to see results rolling out. And I think we all know what we expect to see. But there was an abstract at this year's ACR, last year's ACR, I should say. It was abstract number 0845 that looked at patient-reported outcomes. So it wasn't, tender swollen joint count, but they were very clearly able to demonstrate improvement across the board in patient-reported outcomes with weight loss through pharmacologic-assisted intervention. And so I think there's a lot of reason to believe that these medications are going to directly impact disease activity, and certainly patient-reported outcomes, and certainly weight loss in general does.
So, yeah, I mean, it's great to hear that, to encourage patients that if you lose weight from via any means, whether it's, improved diet, exercise, calorie restriction, surgery, medications, that may help improve your disease activity. And is there any evidence, so you mentioned before that fat is metabolically active and maybe these GLP-1 agonists could actually decrease the levels of inflammation in the blood. So would these be sort of have an extra anti-inflammatory beneficial effect independent of weight loss in patients with rheumatic disease?
That is what we believe, and that's the fascinating part. I mean, this is so, if we really tap into this metabolic pathway of obesity, the idea is that we know that the pathway is such that these adipokines are increasing inflammatory cytokines in the bloodstream. Now, do I have the direct data to say, okay, it's probably been done in mice, right? The metabolic endocrinologists who dive deeply into this metabolic science have done a lot of these experiments and animal models, but I don't have, for example, human data to point to say that, IL-6 levels will drop specifically, but we do absolutely have that disease activity data through DAPSA and DAS28 CRP, et cetera. And what's fascinating too, that I'll just touch on is there are other mechanisms besides that direct talking about adipocyte rupture and release of toxic free fatty acids and or change in the cytokine milieu. There's another pathway that is fascinating and was kind of trendy for a while. You heard about the leaky gut syndrome. So the idea is that when we eat a high fat or quote unquote Western diet, we're actually increasing the permeability of the intestinal barrier because this is altering the composition of microbes in the gut. And this in turn causes increased entry of these lipopolysaccharide or LPS bearing bacterial species into the bloodstream that then also increases systemic inflammation. So there's a lot of chicken or the egg kind of stuff going on here, but we know that inflammation begets inflammation. And the hope is that you can both, through changing the diet and then also reducing that adipocyte inflammatory burden, that you can reduce the overall inflammation levels in the patient in front of you, which is again such a big part of our jobs.
We've talked a little bit about PSA and RA. Any data about the role of these medications in other rheumatic diseases, things like gout or osteoarthritis,
Yes. No, I'm glad you asked.
lupus?
Yes, yes. So so I think there are data in all of those diseases about, the link with obesity. And so let's just start with osteoarthritis because that's again one of the most common comorbidities that we see in our clinic. And I get some rheumatologists kind of along with our sports medicine, physical medicine, orthopedic colleagues will see osteoarthritis in isolation. Some say, well, it has to be concomitant with inflammatory arthritis, but regardless, a significant number of our patients have osteoarthritis. And we know that people with obesity are much more likely to experience knee, hip, and back pain than those without obesity. And we know that weight loss can significantly improve osteoarthritis symptoms by reducing pressure on the joints, particularly the knees, ankles, anything lower extremity. And there's data. This is kind of, if you look at the biomechanics of obesity, a little bit of weight loss can relieve pressure on joints. So, for example, just losing 1 pound of body weight can reduce pressure on the knees by about 4 pounds. When you think about things that you do going up and down stairs, hopping off a curb. So, I think people sometimes are very surprised to hear that a little bit of difference in their weight can have a profound impact on pain in their lower extremities. Then, if you look at gout, it's a little bit more of a complex connection. We know that obesity does contribute to gout. It can lead to increased uric acid production through various metabolic changes, but it also can reduce your uric acid excretion. So, if you look at the kidney's ability to excrete uric acid, this can be impacted by obesity. And then if you tie in that overall inflammatory burden with inflammation begetting inflammation, then people with obesity are more likely to suffer gout attacks through that as well. So, a lot of connections there. We don't have, again, to my knowledge, specific data saying, oh, look at impact of GLP-1 agonists, but we do know that weight loss, a lot of weight loss research in OA has been done, bariatric surgery, diet, caloric restriction. And this is a little aside, but there was a head-to-head between GLP-1 agonists and SGLT2 inhibitors that actually, for gout specifically, and the SGLT2, so for example, Farxiga or Jardiance, those kind of medications that you may have heard of, they were better in this large cohort than the GLP-1 agonist for reduction of gout symptoms. And it's because it was directly increasing uric acid excretion, right? So the SGLT2 inhibitors are blocking resorption of glucose at the level of the kidneys, which is also increasing uric acid excretion. So just kind of a little aside of, for your gout patient, you might not choose a GLP-1 agonist specifically, but these SGLT2 inhibitors, which are indicated for diabetes, may be the better choice for your gout patient, for example.
That's awesome. Yeah, I think there was a paper about the semaglutide for obese patients with knee osteoarthritis that apparently showed some benefits.
Oh, good. No, we need more of this data out because I think we need to encourage people that this is safe and effective, and I'm glad to hear it.
Yeah. So are you prescribing these medications in your rheumatology clinic, or how are you thinking about implementing these drugs for your patients with RA or PSA who are obese?
I am. And in full transparency, again, a year ago or a year and a half ago, my answer would have been no. But I think once you dip your toe in the water and you're like, I feel comfortable and confident enough to do this, that I kind of first do no harm. And I know enough what I'm doing to feel good about recommending this to my patients and getting them started and how it works. And now I actually do this fairly commonly. And it's kind of a mix of people asking me about it, wanting this, and my broaching the subject with some patients who I feel like would be where it would be highly beneficial for them. And fortunately, I mean, I have had a couple patients who said, look, I really want to keep at this through natural means. And I say, absolutely, encourage them 1,000% in that. But fortunately, knock on wood, to my knowledge, I haven't offended any of my patients, which is always the last thing that I want to do, because it's always a delicate subject. You want to bring it up where they just really see you as their advocate, and you're trying to give them all of the tools in your toolbox that you have available to help them. And I think so long as you approach patients in that way, then hopefully no one ever feels judged, right? Or kind of like you're like, this is the real problem, and it's no, you're like, no, this is all part of a package that you're here with arthritis and not feeling well, and we just want to get you feeling better.
So practically, how does it work? You have a patient with RA who is obese, maybe they're on a TNF inhibitor. Do you prescribe, TNF inhibitor and here's your GLP-1 agonist as well? Or when do you think about these, doing these medications? Is it like upfront or if they're not responding or independent of their disease activity?
And so it really depends on the patient and the situation. I think you have your patient again who may be multi-drug resistant, where you're just not getting the last step. I think if you really think about it broadly, we could almost, I mean, if we were seeing ourselves as tackling this almost from a primary care perspective, so long as they meet criteria with that BMI of 27 or higher with comorbidities, we probably could and should be bringing this up to all patients who meet criteria like that, at least to mention it to them, plant the seed, chat with primary care, refer to endocrinology if you don't yourself, feel comfortable doing this, but at least kind of bring it up as potentially a part of the puzzle. I think that's really important. And just in my own practice, I have had a couple of new patients where I felt like in meeting them, obesity seemed like such a prominent potential contributor to their symptomatology, where like the first visit I was bringing this up. But for most patients, it's a down the line. We have an established therapeutic relationship, and I'm grateful for their trust in me and confidence in me over months or years of being their rheumatologist. And most patients, I do think, are very grateful for this option.
Wow. So, can you talk a little bit about sort of the prescribing? Because I've heard there's a lot of challenges in getting these medications approved by insurance companies. So, talk a little bit about so what diagnosis are you writing in your prescription, and are your patients having difficulties in getting these medications approved by their insurance companies?
Yes, that's access is such a huge topic, and it does vary widely by insurance company. So there are some insurance companies that categorically will not cover weight loss therapy medication. So in that instance, you're looking at either a diabetes indication or reduction of cardiovascular risk is another indication in patients with diabetes. And for the companies that will cover it under the obesity umbrella, often you need to include data about comorbidity. So it's some they it's not just the obesity, but you need to add in the information in the code for comorbidity to get coverage. And the other elephant in the room that I'll at least touch on is the compounded version of these medications. So there are patients, well, a couple of options. There's always the self-pay option. So say that insurance is not playing ball, you can get the medication directly from the manufacturing companies, and a lot of the brand name manufacturers do have direct to patient programs. So for example, they might make a vial less expensive than a pen. The compounded is complicated because once a drug is off the FDA drug shortage list, it becomes a legal issue whether or not pharmacies can compound. And so there's some lawsuits that are active currently. It kind of should these various smaller pharmacies be compounding or not. But a lot of patients will get these home injectables compounded, and they're doing these injections out of vials. It's compounded with B vitamins most commonly. So it's a crazy world out there, but the main thing is we just want the right drug for the right patient. Compounded is a little bit less quality controlled. You're not totally sure what you're getting. And so it's nice to stick with the brand name product when you can.
Got it. Do you have any idea of pricing if somebody wanted to pay out of pocket for one of these medications?
So it depends.
Uh,
I'll give you a range. So brand name, starting doses, you could be looking at perhaps about 400 a month, upwards of 2,000 a month, just depending on your dose and the medication that we're discussing. The compounded version, you can, depending, I've heard a range of 80 to about $250 a month. So it is significantly lower for the compounded version, which of course makes it appealing, but then that has the whole ball of can of worms, if you will, with the legal issues coming with that.
Got it. And the reason why those medications are allowed to be compounded is because of the shortage?
So previously, they were on an FDA drug shortage list, aka there was no way to keep up with the demand by the primary manufacturer, and so therefore the FDA mandated, if I understand this correctly, that it was allowed to be compounded, dispensed, distributed by these smaller pharmacies. But once it gets removed off the drug shortage list, then per the patent, that compound should only be manufactured and distributed within the U.S. by the patent holder. That is what has led to these kind of smaller lawsuits. Because, I mean, there are pharmacies out there where these compounded weight loss medications are the vast majority of their revenue. And I mean, you mentioned these drugs are famous, they're everywhere, right? And so there's such a high demand that it's hard to stop the flood the gates for others. Like so many people who are on these who want to continue to be able to access these at a reasonable cost.
Yeah, because I've definitely have patients that have an indication, get approved by their insurance companies, but then they can't get it at the pharmacy because they're out or they don't have the right dose, and they're on the wrong dose for longer periods of time, so they get very frustrated with the whole system.
Exactly.
What have you noticed in your practice of these patients starting, the GLP-1 agonists in regards to their PSA or rheumatoid arthritis or other rheumatic disease?
For the most part, and it's a spectrum. I have had patients who were intolerant of multiple different brands of GLP-1 agonists, even the GLP-1 GIP agonist combination. So it's not one size fits all, right? Some people can't tolerate these, can't take these, but in the patients who have been able to take them, tolerate them, or able to titrate to the maximum tolerated dose, I have seen dramatic effects. I have seen a lot of game-changing weight loss for them. And I think it's important to remember that, again, maintain your hydration, maintain your nutrition, get protein in your diet. And the exercise becomes even more important in this setting because if you take a patient and you just put them on a GLP-1 agonist and they lose 4 pounds, in the absence of exercise, one of those pounds is going to be muscle. So if you take that same patient and put them through exercise, including weight resistance training at least 5 days a week, then for every 10 pounds they lose, only one will be muscle. So it dramatically changes the ratio. So I think a key part of the patient's staying healthy, not just being thinner, but being healthy, is to keep up their or increase their physical activity levels throughout this process. Because we want to keep the muscle, we want to keep the nutrition, we just want to lose some of that excess adipose tissue.
And talk a little bit more about the protein aspect of it. Why is increasing protein intake so important for patients on these drugs?
I think, I mean, if to put it simply, it's because this is the building block for our muscles and in terms of breakdown, inflammation, repair. And so we want to make sure that the muscles have their essential, amino acids and building blocks to not only maintain themselves, but to even hopefully hypertrophy and grow. That in turn is metabolically active and will promote weight loss, right? So it's kind of just like, unfortunately, unwellness can be a cycle, so too is wellness. There's a series of habits and behaviors and from eating and exercise and taking our medications that really promotes the potentiation of that cycle. And so, yeah, I think that whether people join, however they can be cognizant of it, some people do Weight Watchers or do other kinds of dietary programs. I think the main thing is to just not neglect it and, not, even if it's a protein bar or something, but to not forget that that needs to be part of their day-to-day diet.
Talk a little bit more about the side effects that you've seen on your patients and those reported in these large trials. How significant are they and how can they be managed?
Yeah, no, that's a great question. And definitely people need to be forewarned that, I mean, all of these medications, you kind of start low and go slow, right? So you start at a low dose, and after about a month of good tolerability, you can start to increase the dose for increased weight loss and benefit. But diarrhea, nausea, vomiting, can be seen with all of these medications. Some people report a headache. This will get better with time if it's tolerable, right? So if you can hang in there with it for a few weeks, it will improve. But for some people starting it, they're like, categorically no. They just say, I can't deal with this. And if a lower dose is not an option or a different agent is not an option, then that may not be the right avenue for them. And, obviously older methods such as bariatric surgery are always still on the table for patients over BMI over 30 with comorbidities is when we would kind of think about that. But the other thing that I always check with people, I make sure that they don't have history of medullary thyroid cancer, either themselves or their family members. That's one thing that we as providers should know about medullary thyroid cancer. Make sure that that's not anywhere in their history before we give them a green light to start these. And really, that's about it, which is part of what's so nice. We're not using these right now for our pregnant patients. And that would be another contraindication, probably until we have more data. But really, these are considered fairly safe and well tolerated medications, which is nice.
Do these drugs require any routine lab work monitoring like we do for our other medications?
I know, unlike our methotrexate patients and all, where we say come back in a month, come back every 3 months. Really, I am checking albumin levels, comprehensive metabolic panels, but it's more I don't do anything above and beyond what I'm doing for my regular care of my RA, PSA, gout patients. So, and from that standpoint, that's, a fairly nice and easy, straightforward care model.
So how do you think, sort of as a field, we should be thinking about GLP-1 agonists? Should we all learn to prescribe these? I mean, maybe we should, just like we learn to prescribe, I don't know, TNF inhibitors and these new biologics. Or do you think that, maybe we should develop systems so that we can, easily refer our patients to endocrinologists or back to their primary care and recommend that they start on these drugs? How do you envision that going forward?
I know. No, it's a great question. And I think it really depends on the practitioner, because I am so grateful that it is now part of my toolbox that I can offer patients. And so I think for those practitioners who are out there, who are listening, who are interested, I would definitely encourage you, again, to dip your toe in the water, because I think you're going to find that it has a very positive impact on your patient's wellness overall. And, it's rewarding. So I definitely want to be an encouraging voice out there for rheumatology listeners. But for those who are more hesitant, or who say, look, I'm really already at max capacity, I don't have time, or for whatever reason, I don't have the comfort level, I don't think this is my wheelhouse, then referring is absolutely appropriate, be it to primary care, be it to a metabolic endocrinologist, dietitian, nutritionist. Those are all good things to do anyway. A metabolic endocrinologist that I talked to had an exercise physiologist as part of her practice, which I was like, that's fabulous. I want one of those. But, depending upon the layers of specialty care that's available to you, referral is 1,000% appropriate. But I think just having it, the essential piece is that it's on our radar. That this as part of the inflammatory milieu of our patients and a potential contributor to disease development and ongoing disease activity, that's the part that I think is so important for our audience to hear.
Yeah, and I guess as you mentioned, it's not just these drugs, it's weight loss in general. And whether
Yes,
you could accomplish that, with the Mediterranean diet, with increased exercise, with, improving your sleep hygiene, decreasing your stress, all of these things, they would have a positive impact not only in sort of wellness, but in your rheumatic disease control as well.
exactly.
So where do you see this area headed in the next, 5 to 10 years? What do you think is going to happen in the future with all of these medications?
You know, I'm chuckling because before these medications were on the scene at all, I heard a metabolic endocrinologist get up on stage and say that by the year 2030, it is estimated or projected that half of Americans will be obese. And so we definitely had a growing trend towards obesity in our society, which we could try to dissect between stress levels and more sedentary occupations. And I mean, there's multiple contributing factors, but this is potentially something to curb the tide, right? So this is we've got a new player on the scene that may be reversing these weight gain trends in a more healthy direction. And these are newer medications, and a lot of patients of mine have raised the concern, well, what about, long-term safety? And you say, well, depends how long-term we're talking, right? So I understand that concern, but I think unless some new major safety concern arises for these, we're only going to see the usage of these grow over time. And my hope is that, as a whole, we'll wind up with a healthier population. That would be great.
And what happens when patients stop taking these drugs,
Oh, yeah, you're asking all the tough
right?
questions. No, and that's another major concern. Some people say, I don't want to go on these because I'd have to be on them forever. And that's not quite the case, right? So the idea is that the hope is that because these work through, delayed gastric emptying and increased satiety, decreased appetite, that patients can actually change their eating habits in a way that is sustainable. So if through this period of time, through pharmacologic intervention, we can develop new habits that we can maintain after discontinuation of the medication, then you don't need the medication anymore. I've also seen the phenomenon of tapering work well. So we start off with weekly injections, but patients sometimes maintain on a every other week injection or a once a month injection. And so I think there's a whole realm of possibilities out there, but it's definitely not like you stop the medication and you have a rebound effect where you instantly regain all the weight that you lost. That fortunately is not the case. But we do have to have a habit change that goes with the medication in order to be able to taper or discontinue successfully.
Yeah, I mean, it sounds like there's a really bright future for many of these medications in the rheumatology space. And I hope that in the future, as you mentioned, we'll have more data about their efficacy within rheumatoid arthritis and PSA and lupus and gout and OA and many of the other diseases that we treat. So that maybe you're right. Maybe they will become part of armamentarium. It's like, here's your methotrexate, your TNF, and your
You're
GLP-1
yuppie.
agonist.
That's right. It could be.
Catherine, this has been an awesome conversation. Thank you so much for your time. It's really going to make me sort of change the way that I approach my patients with obesity in my rheumatology clinics. And, I've got to think if I'm going to start dipping my toes into this field. But it certainly, if the patients are feeling better, then, and if nobody else is willing to prescribe it, then, maybe we do have a responsibility to start.
Yes. No, I thank you so much for having me. This has been a delightful conversation.
Great. Thanks again. Well, there you have it. Everything you ever wanted to know about GLP-1 agonists in rheumatology, but were afraid to ask. I really never realized the impact of adipose tissue and metabolic health on rheumatic disease, and also the importance of weight management to improve their control. These medications may become a powerful tool not just for weight management, but also to improve rheumatic disease outcomes. It's really a reminder that treating rheumatic disease means treating the whole patient. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this and all other episodes at acronair.org, Apple Podcast, Spotify, and on your favorite podcast app. Until next time, keep fighting those adipocytes. And of course, stay healthy.